So this is a patient who had a penile prosthesis that was dysfunctional, and so they replaced it. And this is sort of immediate post-operative. You can see that there's these canisters, but the air is, kind of within expected limits, immediate post-operative. This is the button that's in the scrotum. And we're going to go up into the pelvis.
Oh my gosh. Wait, where's the reservoir? There's hematoma.
Yeah, there's a big hematoma here, and there's a hematoma here.
Isn't it, where's that? Wait, did it like hit the bladder?
Yeah, so this is a cystogram. I will bring up the cysto part. So we
Oh my
put
gosh. Oh, it was an
contrast
intravesical placement.
fully, and it's outlining that basically this reservoir is in the bladder lumen. So
Wow.
yeah, just and there was extraperitoneal bladder rupture with contrast going into this extra bladder space and a hematoma here. So what happened was because this was a replacement, the other reservoir was like really scarred down, and it took them a long time to like get it out.
It
And so
tore.
then I think when they might have injured the bladder at that time. So then when they put the new reservoir in, it went like straight into the bladder. Yep.
My scar
The
down.
surgery brings you more scarring.
Yeah. Here I can share right, this. Let me give you. Let me give you the small field of views. Okay, so just focus on this.
Okay, I'm thinking there's like a malignancy within a cystic structure. I'm trying to localize.
Yeah, let me here. I'll give you the sagittal.
Just trying to see if it was urethral or vaginal. I don't see the urethra well. It could be like a huge tick, diverticulum of the urethra with malignancy. Or okay, and where's
And
this?
let me give you the post-content. I don't know if that helps, but it definitely confirms the enhancement of the papillary projections.
Yep.
And then I have, I really love fat sat T2s. They're so helpful. Maybe that one.
Okay, it's definitely not the urethra. It's the vagina or
It's hard because the lesion was so big. And so you're like, where is it? And on the sagittal, I thought I could trace a vagina. So here's the
yeah.
cervix, there's a vagina, and I can see it pretty well. So to
And
me,
back to like diverticulum, urethral diverticulum.
yes, that's right. So this was a patient underwent a diverticulectomy, and and do you have any like what kind of cancers would arise in a urethral diverticulum?
You can get adenocarcinoma because there's glands there, and then you can also get squamous because of the stasis.
Yeah, so this was a specific adenocarcinoma variant is clear cell.
Mm.
And this was a clear cell adenocarcinoma arising from a urethral diverticulum. Yeah.
Cool.
And I thought where did I think it was coming out of the urethra? Like I thought I can actually trace it like here, maybe here. Everything's
Yeah, I
getting
always find the neck to be really hard, but
yeah. All right, well, stop.
so this is a retrograde urethrogram. And this patient had remote history of trauma, and now you can see that they have this bulbar stricture with upstream dilation of the bulbar urethra. So just a couple of things about RUG. I used a 10 French Foley catheter, inflated, 4 cc's into the balloon here in the fossa navicularis. I usually put a gauze around the glands so that I can sort of elongate the penile shaft, so I can elongate the urethra. You can see, for example, here, this was not a good angle on it. So the patient should like tilt their hips, and also like you need to elongate it so that you can see the length of the stricture properly. So once we repositioned, we could see that the stricture was pretty long, 2.5 centimeters. If it's greater than 2 centimeters, they usually need to repair it surgically with buccal mucosa. They actually, for this patient, did try to do a laser dilation, and it did not work. It was too kind of narrow and long. So they are going to have to go for surgery. I'm going to pause for 1 second because I have a couple more rugs. Okay, so this was an interesting one also. What do you think is going on in this patient?
Do you have if that area in the kind of the cranial margin of the penile urethra is true? It looks like there's a fistula between the urethra and the spongiosum.
Yes, and the spongiosum is around the urethra, and it was
I mean,
actually
sorry, corpus cavernosus.
cavernosa,
Yeah, yeah.
exactly, exactly. So this was
Got it.
actually a rupture of an injury with extravasation of the penile urethra, and it was actually in the setting of a penile fracture. So there's a whole grading for penile fractures. So penile fractures are usually when the tunica albuginea around the cavernosa gets ruptured, and then the cavernosa extrudes. But in this case, it was also associated with a urethral injury, which is the most severe type of penile fracture. And they had blood at the meatus. So we did this rug, and you could see that there was this focal defect here. And actually, when we went to the operating room, there was not only a defect in the tunica, but there was a 2 centimeter defect in the urethra. So even though we're seeing this focal one here, I think this whole section here was injured.
Wow. Wow,
Yeah.
what a great case.
Yeah, so that's a
Never
rare
seen that before.
Yeah. And here's just one more. This patient, this was just interesting. Is also, and you can see here, my technique is not as good because it's overlapping with the bone, but I tried to get it out of the way later. But the interesting thing about,
So there's like an artificial urinary sphincter or something, and it just
no, it was a
oh,
stent. It was a stent that was placed 20 years ago. So I've never
a
actually
urethral stent.
Yeah, I had
Oh
never seen a urethral
wow.
stent placed, but actually the portion in the stent isn't that obstructed, but like, the
Yeah,
end of it and then the
upstream.
proximal
Yeah,
to it is. And then I think there's some reflux into the Cowper's gland here too.
yeah, I think so. You're right. Yeah.
Yeah. So so I calibrated the bone to a scout so that I could make all these measurements. So basically I was giving the measurement of the lumen at the most severe narrowing, the stretch that like how long it is. Again, it was almost like 2 centimeters. And then, it was less narrow during the stent part, almost 2 centimeters. And then this is the normal part. So yeah, just an interesting one with the stent. And here it wasn't overlapping with the bone, but I feel like I was like foreshortening, seeing the length of the stricture. So I measured it more on this one here. Okay.
What was the stent placed for?
They had also like a remote history. Actually, it was like a football injury where they
Oh
like
wow.
jumped on somebody and then they got a perineal hematoma and a urethral injury 20 years ago, maybe 30 years ago, and then had the stent placed and now still having issues.
This was a adrenal mass protocol to characterize this left adrenal mass here. This is the precon. And then we got a venous and then a 15
If
minute.
it's more than 43, it looked dense on the precon. If it's more than 43, that's suspicious or not.
Yes, that's exactly the teaching point. Yeah, the path just came back and exactly right. So the pre measured 40, I'm sorry, the pre was 44. The pre was 44 and there's areas that are kind of heterogeneous. So I think you have to measure in the area that's like kind of more homogeneous here and
Mm.
not include the hypoattenuating so you don't get like a false Hounsfield unit. Uh, anyways, the pre was 44. So if the pre-contrast is more than 43, like you said, it's non-calcified, non-hemorrhagic lesion, then the absolute washout and relative washout doesn't matter anymore.
But
Because
show me the arterial or the
yeah,
venous. I'm just curious
yeah.
of that
So here's the
enhancement because I know
venous.
pheos have often have cystic spaces, but then ACCs can also get central necrosis.
There's and then and then 15 minutes is here.
Hmm. I'm thinking maybe pheo.
Yeah, so the absolute washout was 24, and relative washout was 7, and this was surgically resected because we said, it's suspicious for malignancy regardless of washout characteristics, and this turned out to be pheo.
Nice.
Yep.
Did they do you know if they did like metanephrines or dotatate?
It was, I don't remember if they did or not. Actually, I don't know.
Okay.
Sorry. Actually, do I know? I think I do know. It was negative. because this was they were following it up. There was a prior, yeah, I think. Yeah. But you know, like it's only positive in like 50% of the cases. So even if it's negative, I feel still like in the differential diagnosis.
Yeah, but we have some PHEOs that we're actually just watching because the patient like isn't hypertensive.
Oh.
And
And
so,
how do
and
you know it's pheo? Like you did a dotatate?
yeah. And also
Oh,
they're old, they were older and they didn't feel like it was like hormonally active enough. Like we basically incidentally found it and then decided it was a pheo and then they were just watching it. Because they're not necessarily malignant, right? So
I see. I see. No, that's great. I did, good to know that active surveillance for non-functional pheo is an option.
I don't think it's like the
Non-surgical
usual
patient.
option, especially for a younger patient, but yeah, sometimes that is. Okay. Okay. So this patient showed up with pain.
There's like a swirling,
Yeah.
and then there's that. Where's that coming from? This small bowel? Or
Yeah.
the,
And it has air in it and
yeah,
it's affiliated with like the small bowel right here, right?
yeah. It's like a, can you show me the coronal?
Hmm. And like you said, swirling. Oops. And then that's the lesion. Oh, sorry. This is the follow-up that was non-con, but this is the coronal with contrast. And I do have an MR, but just based on this, what are you thinking?
Um, I think the swirling was like incidental because I don't really see it here. The or maybe it was the follow-up that I saw it. But
No,
anyways,
no, no.
I
It was definitely swirling. I'll show you back on the axial again, but
oh,
you just don't see it as well here. Yeah. But
okay.
what do you think
But
about
I'm thinking gist. Um, what else? Um, adenocarcinoma is possible, but I feel like gist would be higher on my differential compared to a adenocarcinoma if the patient doesn't have like known cancer history.
Yes, they had no
And
cancer
then
history.
maybe it's
And
like a
then,
diverticulum that then had cancer in it. But it looks malignant. It looks but I mean it looks bad and there's a swirling. So is it related to the swirling? Like could it be but I think
so one other thing that came up was like, is this actually just aneurysmal bowel? Like this is lymphoma kind of thing. Like this is the walls of the bowel and this is the beginning of the aneurysmal part. So I'm just going to show you the MR also. It was swirling again still.
but I think it's incidental. I don't think there's complications from that swirling. Um, but I don't know. Okay. All right. So now we see this. So lymphoma, they classically restrict a lot
Mhm. They are
and
usually more homogeneous. This is like pretty heterogeneous.
homogeneous, but we've seen like non like heterogeneous cystic looking lymphomas too. So I was gonna say they're usually solid and homogeneously appearing, but yeah. Oh,
Lot of,
it's just a
Mhm.
lot. Yeah. So um and I mean I get that's not really something you can biopsy, you know? It's not a
Yeah,
um
so they ended up going to this to the OR and this was a gist. And what it was like we were still kind of like tricked out a little bit, like, hey, is this aneurysmal dilation? But we decided, either way. Oh,
yeah.
and by the way, it was volvulized. So it had volvulized, there was mesenteric engorgement, and this was the lead point. So basically it was this
Oh
pedunculated,
wow.
it was this just hanging off of the small bowel that had eroded into the lumen, which is why you had like mucosal ulceration. That's why you had air in the mass. But this
Yeah.
wasn't like, aneurysmal dilation of it. This was just hanging off of it with communication with the lumen. And
Yeah.
it was acting as a lead point for a volvulus.
So the mesentery is supplying that mass, right?
Yeah.
That's what you're
Yeah.
saying?
I mean, supplying the small bowel
Oh,
that.
I see it. Wait, do I see
Right.
it?
Yeah.
Kind of. I mean, one of the vessels go into it, but the other vessels look okay. I don't really see the mesenteric edema, but maybe there's maybe that. Yeah.
Yeah. This stuff here.
Yeah.
Yeah.
Yeah. The haziness. Yeah, that's more obvious there.
And one of the things they said in the path report was that there was like ulceration and sort of like necrosis, but they didn't know if it was related to the volvulus or just from the mass itself. So I don't know. They kind of hedged on like what that was related to. I think it was probably just the mass itself, but there was some mesenteric engorgement because of the volvulus. So yeah,
Wow.
volvulized
Cool.
gist. Yeah, very cool.
So it's just like venous ischemia.
Hmm. And I guess like one take home, you said like the lymphoma can be really restricting, but generally tends to be a little bit more homogeneous and yeah, this is
Yeah,
kind of
generally. Like it, lymphoma doesn't obstruct, like it more encases, but that's not true either. It can obstruct.
yeah.
This is a patient who came in with flank pain. Um, and there's we said there's not really any obstructing stone. We said maybe there's something in the bladder here that's hyperdense.
There's a lot of stranding around that big prostate.
Yes, let me pull that down. So there's some kind of hyperdensity there. Maybe stranding around. I don't know. I don't really.
Or like around the
Read a
whole
little
bladder
bit.
and prostate, I feel like they're stranding, but
Yeah. Perhaps. Yeah. Maybe the movie kind of cystitis or something. Um. Okay. What else?
so like you put it on bone windows for a reason. So I'm looking at the bones. They're like acetabular fractures on the left. No. Oh,
There's.
yeah, there's like a lucent bone lesion.
Yeah. Yeah. And if we look at the. It's subtle, but it's there.
Yeah, definitely.
Yeah. So I'm showing this case because, there are certain areas that are known pitfalls for abdominal radiologists, and one of them is the bones. So just, no history of cancer. This is like a new finding. So, um, we just have to be careful to make sure that we, uh,
And with that bladder thing, or like, did they get that worked up? Like, are these bladder cancer mets or?
bladder did not get workup, but patient did represent. Um, and it was actually at that time that the bone stuff was picked up. So they're getting worked up.
Yeah,
And then
definitely a
and then
pitfall.
there's a
Especially like he's
fracture.
the osteopenic here, too,
Yeah.
right? So that one in the spine would be easy to miss too.
Yeah. Oh, absolutely. Yeah. And now there's a fracture in that one. So
Good reminder.
yeah, lung bases, the edge lesions at the top and bottom, images. Peritoneum is also a known pitfall. And actually we miss quite a few stuff in the pancreas because it can be so subtle.
Yeah. I basically have my MSK friend on like speed dial now. And the take home that I usually get is like, oh, we need an MSK MRI. But but sometimes it's been really, really helpful. So
Yeah, I agree.
hey, Nelly, what do you think about this?
Oh my goodness. What is going on here?
This is
Okay,
actually
so
flipped, but this intra-op? What do you think this study is?
so probably a cholangiogram,
Uh-huh.
and the biliary system looks totally weird. There's drainage into the jejunum,
Yep.
and there
CTD,
is
duodenum.
fistula. Is there fistula? Like there's weird kind of in the left liver, overlying left. There's like these vascular or what looks to be like branching vascular. So I wonder if there's a fistula between the biliary system and um, the vascular tree.
Good thought. This is just a
A lap band.
yeah, lap band. So I just thought this was like kind of a crazy looking cholangio, and it's like, what is this disease process? And turns out it is just a patient with a massive cyst in their liver.
Oh my goodness.
So massive, massive cyst. And then, so just from like the chronic obstruction of their bile ducts and compression of their liver and the biliary system, the bile ducts ended up like that. So they fenestrated this and this came back cyst. It wasn't a MCN or anything like that. It didn't have any really complexity to it, but just like the biggest cyst I've ever seen. And they were,
Wow.
but yeah, when I first,
So what was the reason they did the like intraoperative cholangiogram?
just to make sure that the bile ducts were okay, because they like, it was, they were scraping away at this huge cyst and just to make sure
Oh, I
any
see.
extravasation.
Oh, I see, for bile leaks.
But like, yeah, this is just chronic changes of the bile ducts because of all the obstruction.
That's incredible. You
Yeah.
don't, I don't really appreciate the mass effect. I mean,
Well, this is after they've fenestrated it. So,
oh, I
so
see.
like the now he's got the band in, so they've taken away the cyst, right? So it's
Okay, got it, understood. So now
gone.
it's kind of like reoccupy the space that it previously
Exactly.
didn't have. So now it's like filling up whatever.
If you look though, like those dilated, but those were these scrunched up bile ducts that were over here
Yeah.
that were dilated because of chronic compression, and now they're just like taking up more space.
It's incredible what the body can do, right? I mean, that it like, I mean, oh my gosh.
Yes, the person must feel a lot lighter.
And flatter.
Yeah. Okay, pause. Okay, quick one here. Just what do you think about? Okay, there's a cystic lesion here. Show it to you on the. Okay, there it is. Cystic,
Wow. Okay.
and
Just in the hands.
there was question of a nodule here. I'm going to show it to you on the coronal.
Okay.
It's a 70-year-old female.
Is and there's a little, is it communicating? What is it communicating with? There's like a little tail.
That might be part of the pancreatic duct. I'll show you some
Oh, maybe
MRCPs. So the
that's
pancreatic duct
a
is here,
periambulary cystic thing. Maybe? No, it's anterior.
and then there's this part, right? So
Yeah.
it was like, oh, there's like a
Septa,
second cyst, or is there a
thickened.
nodule?
Yeah.
So I'm just going to tell you what happened. They went for EUS and they saw mostly a unilocular cyst with a mural nodule.
Yeah.
They biopsied it. The cytology did not come back positive. The CEA was low and the amylase was 150. So they ended up going for a Whipple because they said, this is probably an IPMN, and it came back serous adenoma.
Oh, wow.
Yeah.
Like an oligocystic variant?
So
Oh,
just a
wow.
cautionary tale, there's 10% of serous adenomas are oligocystic.
Yeah.
What was supportive of that is like this lobulated kind of appearance, right? IPMNs are more tubular usually, but
Yeah.
when I see
And
this,
MCNs are more encapsulated. Yeah.
no, yeah, neither of them have capsules, but IPMNs are more like a dilated, one
Wait,
dilated.
MCNs have capsules.
IPMNs?
MCNs.
Oh, MCN. Yeah. Sorry. MCN is more encapsulated and it's
Yeah.
usually body tail or tail.
Right.
But yes, and then usually more kind of smooth browned border because of the
Yeah.
capsule of the green stroma. So when I see something like this, I give the differential serous adenoma versus IPMN. And usually the EUS helps. In this case, it was kind of helpful in that the CEA was low. So that should have been sort of that does kind of go along with serous adenoma rather than the elevated CEA we see in mucinous lesions like IPMN and MCN. But the sort of like anomalous thing was that the amylase was a little bit high, 150. And I believe sometimes the amylase is falsely high because you're going through pancreas to get to this. So like you can hit some ducts and get some amylase. So anyway, just a cautionary tale. There is something called an oligocystic serous adenoma. They tend to have these lobulated edges. They can have like one or two cysts. And so just give the differential if you're in that, if you see something like this.
What was the size? Under
Um,
3. So
uh,
they did it just because of the amylase? Like patient was not symptomatic, the
They
size
did it
wasn't
because of the mural nodule that was called
serious. Oh, I see.
on
Did it enhance?
um like so small it's hard to like totally tell. But oh yeah,
Oh yeah.
yeah,
Yeah, it
okay.
enhances. Yeah.
Right. But that's actually probably a cluster of like what do you call it? Septations, like enhancing septations from the serous adenoma. But
Oh, I
yes,
see.
it was
It's
because of
difficult to
this.
distinguish. Yeah.
Yeah. And the EUS they said they saw a nodule too. So
Yeah.
right. This was a tricky one.
Yeah. I think it was the right thing to do though. I mean, based on the guidelines and what the current recommendations are.
Right. Enhancing nodule, definitely.
Yeah. Yeah. And I mean, oligocystic cystadenoma, I mean, you can propose it, but the imaging findings are discordant with that. I mean, but with the nodule, I mean.
Yeah, exactly. We have had some where we proposed it and they did an EOS and it came back like, either they definitively said serous or the CEA was low, amylase was low, and we just like watched it.
Watched it. Is serous cystadenoma diagnostic on EUS? I mean, can it be diagnostic?
It can be. Yeah.
Oh, okay.
Yeah, I have one where it was, a lot of times they'll say paucicellular, no abnormal cells, and the CEA is low. And then we
Oh,
presume it's a serous, but yeah, it is a little bit harder to get because you
yeah.
have to get like these cuboidal cell, like the septations that have cuboidal cells that are like secreting the serous fluid.
Oh, I see.
Yeah. So usually it's paucicellular.
You could be a pathologist.
No, no, I only know this because of my ARP lectures. Okay, see you later.
Thanks.